Hi guys. So yeah, we are starting our session for today, and that is we are solving the September 2022 mock 1 paper. Question number 4 to 6. We have already solved 1, 2, 3 in the last session. So yeah, let's just start immediately. A man in his 40s comes to your clinic complaining, "My teeth are rotten." I hope you guys can hear me. If not, leave me a comment. He has undergone radiotherapy due to his oral squamous cell carcinoma on the buccal of the posterior molar 5 years ago. Oral examination showed that all teeth are decayed, black caries, some missing and broken teeth, obviously dry mouth. So he's complaining my teeth are rotten, and when you see the picture, you can see all the cervical caries happening, and he has gone radiotherapy. So somewhere we are going to deal with radiation based caries, okay, and we have dry mouth because salivary glands also get affected when radiotherapy is given, so understandable that he's having, but you can also see plaque actually a little bit, and you can see the front teeth, one is grossly decayed and broken, and the others, the crown structure still looks fine, but the root and the cervical is completely destroyed. Alright, so let's see what the questions are. I would suggest you for this question, and not only for this question, take out a nice radiotherapy article. I had shared recently a very good relevant article to all my enrolled candidates on the group. So if you can find that article, do it. It's a very nice article because that article mentions what dose is given for radiotherapy, from which dose the teeth start get affected when you're giving that dose for radiotherapy. It's not like if the patient has taken radiotherapy below a certain dose the teeth will get affected, not necessarily. They get affected on a certain dosage, and when you have to do the treatment before radiotherapy, when you have to do it after radiotherapy, etc. So a good article on radiotherapy is very important, and you should know about this. You may not find this in textbooks, so just Google. Let me see if here I've attached the link here in my explanations. Let me see if I can find, then you can just go through it. Now, first question is, what is the most significant factor that is attributed to his present caries status? Question is asking his present caries status. What is the most significant factor? Dose he received from radiotherapy, the medications used for treatment. Now the question is not mentioning chemotherapy, so we have to believe that it's radiotherapy. So the medications used for the treatment is kind of a right answer, but if I have a more specific answer, I'll go with that. Amount of existing caries in the mouth, his previous caries experience. Now his previous caries experience would have mattered, but then would it matter in the present caries status? To some extent, but more than that, because he had taken radiotherapy, and radiotherapy is known to cause radiation based caries, again this becomes a vague answer. The patient wasn't able to keep up with the fluoride. Well, fluoride helps only in the incipient lesions. It does not help in more graver problems, and this is like gross caries. Combination of chemotherapy and radiotherapy. I would have opted for this answer, but then the question does not mention that he took chemotherapy. So the only option that is correct for me for this question becomes dose he received from radiotherapy. Now you have to remember a certain dosage. I think I have mentioned here, yeah, in my explanation. Yeah, this is the article, Do you want me to click on this article? Let's do it. So this is the article that I had shared in the reference. I always provide article references if it's needed, and this was a very big article. Very nice article, and this article mentioned, let's go to the place where how much, I think I can go back here. Yeah. It was observed that minimal tooth damage occurred below 30 Gauge. There is this radiation measurement, I think it's called as gyra, something like that. So below 30 there is minimal tooth damage, but the tooth damage increases by 2 or 3 folds when the radiation is between 30 and 60. Now, normally around the dosage of 50 gyri is given for the face and neck radiotherapy. So, of course, it's more than 30. This is a little technical based question, you know. Logic is not going to help you here. You have to know the concept and what it is and what are the measurements. So, write it down, make a note of it, read this article I've shared here, you know. So, to all the enrolled candidates who have solved this, the link is here, print it out and do it. So, I hope this is clear. Any questions regarding this? I hope you are understanding what I am saying. Guys, can you all hear me? Yes, no, somebody write a comment. Can I see the comment? I cannot see any comment. Yes, Abir, Kritisha. Okay, fine, I can see your comments now. Now let's go to the second question. What is the significance of this diagnosis? So what was the diagnosis first of all? The diagnosis is that the teeth are affected because of high dose of radiation. What is the term for that when there is caries because of radiation? Osteoradionecrosis, correct? That happens in the bone, but this is radiation caries. Now, what is the significance of this diagnosis? This is a very important word. This means the diagnosis of caries happening due to radiation. Understood? The whole enamel and dentine may be affected. No. Okay, let's just understand what happens during radiation. Okay. See, when radiation is there, it will kill certain cells and tissues and it will decrease the blood supply basically by stopping growth of the blood vessels so the tumor area can die. Understood? Now, when you are stopping the blood supply to a certain area, the teeth which are in that area will also have reduced blood supply. Understood? Now, when the blood supply is reduced, the pulp cannot nourish the dentine. Dentin has tubules and it receives nourishment from the pulp. Enamel does not have tubules. It is not receiving any nourishment. It is 96% calcium. It's absolutely inorganic. Dentin, on the other hand, is a very organic structure. It's a live structure. So, the dentine will get affected because the pulp got affected, because the blood vessel supplying to it got affected. Is this concept clear? So, what should be affected in a tooth? Pulp should be affected and dentine should be affected. Enamel will not be affected. So, now let's read the question. What is the significance of this diagnosis? This diagnosis means the problems happening due to radiotherapy. So the whole enamel and dentine may be affected is not correct because enamel will not get affected. Very painful condition, not necessarily. Like, of course, things are dying inside your mouth. They are not growing properly. But is it painful? Not necessarily. The whole dentine may be affected, but the enamel shell remains largely intact. Correct. Norulain Anwar, I guess every article has different values. So what is the legit way to opt for one? Follow this one because this is by NCBI. This is like a very reputed journal. And I asked my oral surgeon friends also. So both of them validated it. So I will go with this. PubMed index journals are legit ways. But even in, there is this big fat book called as Mish. It's book of implants and it's certified by various governments when people appear for their implant exam. And in that book also the same thing was mentioned. So I'm going to go with this. All right. None of the above is not an option because I have the option C out here. Coming back to the question. So the answer becomes the whole dentine may be affected because like I explained the concept of what happens. I hope the concept is clear. All of the listed items are early adverse effects of radiotherapy except. Now, when you have such a question, like I always see in my previous explanations, when they say all of the items are early adverse effects, meaning all the options that you're going to read are going to be correct except one of it. So when you will start reading the question, in order to not get confused, you're going to read it like this: all of the items are early adverse effects of radiology. Candidosis, is it an adverse effect? Yes, it is. Skin burn, it is an adverse effect? Yes, it is. Oral mucositis, is it an adverse effect? Yes, it is. Taste alteration, is it an adverse effect? Yes, it is. Loss of periodontal ligament, have you heard of it? No, you have not. Can it be caused? Not necessarily, but usually not. You never have read that after radiotherapy the tooth became loose and fell off by itself. Like, it's very rare. But it can happen, but very rare. And definitely that will happen in the later stages, not in the early adverse effects. So, is loss of periodontal attachment an early adverse effect of radiology? No, it is not. So that should be my answer. Because many a times when you are solving question after question and there is a deadline, you tend to forget the mention of the word except, and you will mark something which is actually happening, and then you will think, oh, such a silly mistake that was, but that silly mistake is going to cost you your exam. So this is how you solve the exams: except, which is true, which is the only option is wrong. Understanding? So, what are the dental treatment options for a general practitioner? You are appearing for a general practice exam, so they are asking you what is the most basic thing that you can do. Not a specialist kind of a thing. So, what you can do in such a patient? Can you do implant construction after cancer treatment? No, you cannot, because you need extra training and studies for it. As a basic GP, you won't be. Yes, you can take training, but do all the BDS have training? No. Even I don't have. As a specialist, I'm a perio specialist, and even I don't know how to construct things by implant. So definitely, being just a plain graduate, you won't know this. Can you do extractions or periodontal surgery? Okay, you may be able to do extractions, but can you raise a flap and do some periodontal surgery? No. Can you do restorations, root surface debridement, and use of local anesthesia? Yes, you can do that. You can do that because these are the basic things and you frequently do this. It is best that the patient manages with dentures. Well, this patient has teeth, so why do you want to remove all of them? And plus, removal of teeth after radiotherapy is not a good option because blood supply is already less in the bone. And if you remove teeth unless required, there would be massive delay in the healing leading to osteoid necrosis. So you don't want to do that. You want to preserve the teeth as much as possible. So is it the best option that the patient manages with dentures? No. Plus the question also mentions that the patient has very low salivary flow. So saliva is very needed for retention of dentures. Why do you want to put him into a very difficult situation? E, answer all of the above. Now somehow whichever candidate answered this question chose all of the above. No, all of the above are not the treatment options for a general practitioner. The only option is C. So Kritisha, yes, you are right. The only option is C. So this is the explanation provided. But anyways, let's go to the next question. How to restore his front upper teeth? Okay, let's go to front upper teeth and let's understand some concepts. Okay, where is our front? Yeah, these are the front upper teeth. Now, if you see the front upper teeth and I take from lateral to lateral, so lateral, central, central, lateral, one of the lateral is grossly destroyed. Now, honestly, I would do root canal in this tooth and then do a crown or something on it. But but is the crown needed on that 1-1? No. Is the crown needed on 2-2? No. A crown on 2-1 may not be. Okay, if crown is an expensive option, then what is my next best option? My next best option would be composite restorations, a full composite veneer, direct or indirect. After composite, what is my next option? Then it would be resin modified glass ionomer cement. If that option is also not given, then I'll opt for normal GIC. So this is my hierarchy. Now crown is a really good option for the tooth 1-2, but it's not a good option for tooth 1-1. Plus crown becomes expensive. So whenever as a general practitioner a patient like this comes, you have to give him the most affordable option. So you cannot just directly jump on the crowns. So let's see what are the options here. RMGIC. RMGIC would be my first option of choice if the question would have mentioned which is the best restoration for his back teeth, not the front teeth. As soon as they say front, composite has to take priority. If they say back, then RMGIC takes the priority. So you see, just by changing the teeth anterior or posterior, my answer changes and I'll keep the same options. Are you getting my point? This is how important it is for you to read the question properly. So porcelain, GIC, give veneer, all are correct, but not in the right order, especially if resin composite has been given as an option. So I will choose here resin composite. Is this question clear? Is the concept clear? So now we move on to the next question. Any questions you all have regarding this radiotherapy before I move on? I'm giving you 30 seconds to answer. It's not like so no questions regarding this question, correct? So I'll move ahead. Mandibular right lateral incisor has a apical radiolucency that was discovered during a routine examination. So when you say it was discovered during a routine examination, meaning the patient is not having any pain, correct? So let's keep that clear. The patient does not have any pain. You happen to discover this. There was a history of trauma more than 10 years ago and tooth was slightly discolored. So the tooth is slightly discolored. Whenever there is discoloration and the IOPA shows a radiolucency like this, that means the nerve has died. The nerve is necrotic or it is calcified. Now in this particular IOPA, you can actually appreciate the presence of pulp as this radiolucent line. So it is not calcified. Yes, the apex is not developed and there is a periapical lesion, but there is no pain, there is no symptom. The adjacent teeth responded normally to pulp testing. So adjacent teeth pulp testing has been done. Patient concerns about tooth color and wants a treatment for that. So the patient concern is, I want to change the color of this tooth because it's necrotic, it must have become black. Okay, let's read the question. What investigation will you do to diagnose the tooth condition? So let's go back to the question. What does the question say? The adjacent teeth responded normally to pulp testing. Does the question say that this problem tooth has been pulp tested? No, they have not. And even though you know it's necrosed, you still have to do a pulp testing. So many people, like nicely this question has laid a very fine trap, it's leading you, look, this tooth is dead, look, there was no symptom, look, there is a radiolucency, look, we have tested the pulp of the adjacent teeth. So definitely when you read this next question, like this candidate has made a mistake of choosing palpation as an answer, you'll do the same and you'll be wrong. And you'll be like, what? I had marked the right answer in the exam. The question mentioned pulp testing was done. But did it mention it was done on the same tooth? No, they said on the adjacent teeth. Got my question? So, what are the options here? Heated instrument. Heated instrument you can use, but that's a very like later resort if you don't have anything else. Percussion you can do, yes, but is it my first choice of investigation? No. Palpation you can do, but is it my first choice? No. Cavity test, no, again not my first choice. Electric pulp test, yes, that is my first choice, because I have not like 100% made sure that the tooth is dead, because nobody has done pulp testing on that. Pulp testing has been done on adjacent teeth. Understood? You saw how nicely this question trapped you, and it was such a simple question. Getting my point? Yes or no? Next, the tooth did not respond to sensibility test. What could be the pulp status? Pulp status is necrosis. This is like a very simple question. Like you can just answer it with closed eyes. Yes, good. Good, Abraham, Kritisha, Neha, Huma. You understood the concept. Now you understand how nicely silly mistakes you people can do when you don't read the question properly and when you are in a hurry. That's why never be on a hurry. And to not be in a hurry, you need practice of solving the mock test. So, big explanation for this for your revision purpose. See, when I take such effort to write an explanation, you people are supposed to read it so that you can revise it. When you solve a mock test, it will take you 2 hours. When you will revise it, it should take at least 5 hours, because you are reading all the explanations, you are understanding the concept, so that you don't commit the same mistake again in the next mock. If you don't improve mock after mock, then you should seriously think, why are you even solving mock? Getting my point? Now, what is the periapical status if your examination revealed there was no tenderness to percussion or palpation in the region? So basically the question is saying there was no symptom, but there is an apical radiolucency. So if there is no symptom, that means it becomes asymptomatic. But asymptomatic what? Is there an abscess? No. An abscess can never be asymptomatic. It will always give you symptoms. Apical periodontitis, yes, it is apical periodontitis, and it's an asymptomatic apical periodontitis. Actually, the very accurate diagnosis should be chronic asymptomatic apical periodontitis, but they have not given that option. They have given chronic symptomatic apical periodontitis, chronic apical periodontitis. Okay, so they have removed one word from each of the option. The absolute correct option should have been chronic asymptomatic apical periodontitis. Correct? So now what is the complete diagnosis? So now see, if you answer any of the above two questions wrong, where it asked you about the pulp diagnosis and the periapical, then you will surely answer the question 4 wrong. But if you answered that correct, then you can easily answer this fourth. Pulp necrosis. So what Hamda is asking about the option D, you are asking about chronic apical periodontitis, this one. Hamda got the point, right? Because it just mentioned chronic apical. Chronic apical can be symptomatic also, correct? So the word asymptomatic has to be there. Difference between acute and chronic. Acute will always develop in less than 7 days. It may not have any radiographic significant feature to be appreciated. You know, sometimes you must have seen in your own practice, suddenly the patient will come, doctor, this tooth started hurting so badly since last night, I can't sleep, I can't bite. You take an IOP and the periapical area is absolutely fine, there is nothing, and yet when you start doing root canal, the patient is so much pain, you have to give intrapulpal, you have to give 2-3 times the anesthesia, and the pulp is heavily inflamed and it's bleeding like crazy, you know. So that is called as an acute scenario. Chronic, But usually chronic is asymptomatic, not necessarily. Have you heard of this term called as acute exacerbation of chronic periapical abscess called as a phoenix abscess? In that scenario, the chronic thing is symptomatic because of the acute exacerbation. So no, acute is less than 7 days. It may not give a radiographic implication, and it is usually painful. Chronic can be dull pain, can be no pain, can have episodes of pain and no pain. Got my point? Do not confuse chronic as being silent. Chronic is something is happening but at a very low grade level. For example, take that case of hyperplastic pulpitis. You know that pulp comes like a balloon in the tooth. That's a chronic case and that's a painful case. Got my point? So yeah, the diagnosis here is pulp necrosis, asymptomatic apical periodontitis. Now what will be the treatment sequence for the tooth? So let's go with the option of extraction. Can you do extraction? Yes, you can do extraction. But is it the conservative treatment? No. Surgical endodontic treatment, apicosectomy and bleaching followed by permanent restoration. Surgical endodontic treatment means it's a apicosectomy. That can be done. It's not a bad option actually. But you never will jump onto the surgical side unless your normal traditional way fails. So option C is also correct, but that is at a later stage. Bleaching followed by endo treatment. Oh no. The tooth color is discolored because of the inside pulp clotting of the blood. So bleaching it without doing endo treatment is stupidity. So you will not do that. Endodontic treatment followed by bleaching and permanent restoration, very good option. So you first remove the pulp, you clean that area, then you can do a walking bleach technique also. Sometimes the tooth may just get white just as it was because of the walking bleach technique, or even if it doesn't, it will definitely lighten its color after the endo treatment is done, and then you can give a permanent restoration. So the option A becomes the correct answer, though the other options are correct except option B. So now I can also ask this question like this, what will be the treatment sequence for, so all of the above can be the treatment sequence for the tooth except, so if I give you this question and the same option, so now the answer becomes bleaching followed by the endo treatment. So the ADC people can just switch one or two words and your answer will change, and they can give you exactly the same question as asked in this exam. Correct? So again, your concept has to be clear with this. So Dr. Aman Sachdeva is asking after how much time we go for the bleaching? A week later or 2 weeks later. You don't wait much. Can you please repeat, ma'am? What should I repeat? What do you want me to repeat? Yeah, tell me what do you want me to repeat. I'll repeat that. In the meantime, let's finish off the last SBQ for today. SBQ6. Such a pretty rubber dam color this is actually, purple. No? It's very cute actually. The last sentence. I don't remember what was my last sentence. I think you should just go back to the recording once I share. But anyways, if you were asking about how the question would be asked in the exam, what I was saying was, if the question here, I change this question and I tell you that the question is all of the following are the treatment sequence for this tooth except, then the answer becomes D, because you will never do bleaching and then endo treatment because the rest of the options are correct. So this is what I meant, that in exam they can give you the same question like the same SBQ with all the above 4 questions and will change just 1 or 2 words of this question and your answer will differ. Takdees, yes, the recorded session will be saved, but I will not save it on the Facebook because a lot of people are using my stuff, my hard work and just distributing across, which I don't like it. So I will save this recording and I will share it for all the candidates who have enrolled with me. Like I will share it on YouTube and I make it private. So and then I will share the link to all the enrolled candidates. So they have the access, but not everybody will have the access. So this is the only way you can get things from me when I conduct a live session. The rest, all the enrolled candidates gets. In fairness, I mean, everybody like is devoting their hard work, time, money, energy. So they should get what they deserve. It should not be just free floating around. So, anyways, will the open apex affect the agent used for walking bleach? Gunveer, walking bleach is done in an endodontic treated tooth. So first of all, you will be doing endo treatment. Once you are done with endo treatment, you're going to seal it with the GP. And then if you would have read how walking bleach is done, you remove a small portion of your GP, 1 or 2 mm, and then you put the walking bleaching agent, which is what? Sodium perborate and hydrogen peroxide mixture, and then you seal it off with the ZOE or a GIC, and then you leave it for at least 2 to 3 weeks. So open apex is not going to be affected in any way because you have already done your endo treatment, which can be either through MTA or putting a higher size of GP point and sealing the apex off. The only disadvantage of walking bleach that can happen is cervical resorption. That is if the bleaching agent leaks out from the dentinal tubules from the CEJ area, that is cemento enamel junction area. Understood? I hope this is clear, but walking bleach is an important topic and it will be asked mostly. So read about it. Hello? I don't know, somehow. Okay, I can you guys hear me? Yeah, so I hope this is understood. I thought the net got disconnected or something. So you're there, right? Just somebody write a yes or something. Then I'll continue. Yeah, Abir, thank you so much. Okay, so let's go to the next question. Female patient presented at your clinic complaining of a broken amalgam filling that fell out on 2 different occasions. So the picture that is mentioned here, already 2 times the filling has been dislodged. There is no pain, but she feels discomfort due to food getting stuck in the cavity. Of course, it's an interproximal, food will get stuck. You examine the tooth sensibility, which was normal. No tenderness to percussion, and radiograph showed no abnormality. Now, good that this question came in this session. You remember the first question when it's the previous question actually, when it said that pulp sensibility testing has been done for adjacent teeth, but it did not mention it was done for this tooth. In this question, what it is saying, it says that we did the tooth sensibility for this tooth. The question does not mention that we have done for the other teeth. Now, by default, in Australia, or actually anywhere else in the world, it's a good practice. But in Australia specifically, because you're appearing for the exam, whenever a patient comes with chief complaint for any one tooth, you will do pulp testing for the adjacent teeth as well. Then only it would be classified as a complete oral examination. You understand? And it's a good habit also. You don't know if this molar is non-vital or necrotic. Correct? So you don't know that canine is necrotic. So if you just work on this premolar and later on the patient has some problem because of the canine or the molar, and then they come back and you discover, oh, this was necrotic, so you can be held liable because when the patient came to you for an examination, why did you not check the other teeth? I understand. You may then say, then why not do pulse sensibility test for all the teeth? Correct. But the problem, chief complaint area is this now. So you don't want any other problem after you finish the treatment in that area. So at least for that area, the adjacent teeth, the pulp sensibility testing has to be done. Correct? Makes sense? So let's go to the other question. Which investigation would you do? So now that I've explained you this, you should be able to answer this. Pulp sensibility testing. Percussion. See, percussion is not wrong, but always the priority will go to checking the nerve of the tooth. That is the pulp. That is the first, and then you check the surrounding areas, which is like percussion. Percussion is not correct in this. I mean, it's a correct option for investigation, but does it take priority? No. Pulp sensibility and cuspal loading. Well, that is kind of correct, but when you cannot see a physical fracture, and not only that, what does the question say? There is no pain. If there was a crack, the question would definitely mention that the patient has pain on biting, but there is no pain. And specifically, the question mentions she feels discomfort due to food getting stuck. So, though this is a very logical option, because the question is mentioning there is no pain, I will not choose this option. Probing is a good option, but it will come only after pulp sensibility. Transillumination, again, it's a crack tooth thing. You can do if you would like, but is it my list of priority? No, it is not. Hence, pulp sensibility. All the candidates that appeared for this mock had answered this question wrong, and they were all. Why is the option A the correct answer and not the other? Now you understood why. Correct? Cusp loading is taking a gutta percha stick and biting on the tooth to check if the cusp can bear the load of the GP stick or the biting pressure. That is called as the cusp loading. Understanding this? Can't see the questions and the options? No, you can because I switched the screen, because somehow I was reading the comments from my phone, and somehow from my phone the live session disappeared, so I cannot see your comments, so I have to switch back and see your comments. So let me finish off this scenario based question number 6 completely, then I'll come back on my laptop to ask you the comments and the questions, then you can ask me. Okay, so I hope this is clear. The amalgam restoration fell out on 2 occasions. What would be the next management to avoid this issue? Okay, so clearly amalgam is not retaining. So it was done first, it fell out, and then on 2 different occasions also it fell out. So 3 times this filling has been dislodged. And looking at the cavity, it's all flared, and amalgam is not going to stay there. So might as well you remove this piece and do some other filling. Now because it's a premolar and she's a female, aesthetics is of important. So as much as I would love to do an indirect ceramic inlay, which I would have done personally as a clinician, but indirect ceramic inlay becomes an expensive treatment. So I will first opt for composite restoration. Crown lengthening and inlay, no. If I'm doing an inlay, why will I lengthen the crown? They are 2 contradictory statements, correct? Indirect ceramic inlay is the best option, but it's an expensive option, so you will not opt for that. But as a clinician, I would do ceramic indirect inlay. But anyways, remember, for ADC, always the affordable option comes before the expensive option. Composite restoration becomes the right answer. Pen amalgam you should not do because sensitivity will develop. Plus, amalgam is no longer preferred. It was done, but you don't have to repeat it, and plus putting a pen would further compromise the compressive strength of the tooth. It may help in retention, but it will compromise the compressive strength. RCT post followed by the crown. Wow, that means you want to intentionally do root canal and then give a crown. Totally aggressive dentistry. It's not a wrong option, but it's a very aggressive dentistry, and we follow the minimizing the restoration approach, minimally invasive dentistry. So the answer becomes composite restoration. Now if the tooth cavity was looking like this and the tooth had a root canal filling, so basically this area is treated by root canal, what can be the most affordable and acceptable management? See, looking at this, the first option in your head will come, let's give a crown. Fair enough. You can't give a crown, give a onlay. Again, fair enough. But then what is the question mentioning? Most affordable and acceptable management. So now you have to think what is affordable. Is crown affordable? Not necessarily. Crown is an expensive treatment. Onlay ceramic again becomes expensive. Now crown lengthening and inlay. Lengthening is not required. The crown structure is great. So again I will remove that option. Indirect ceramic inlay. I will still opt for this, but again it becomes an expensive option. Composite cusp capping. Now that becomes an affordable and an acceptable management. How long it will stay, God knows. It may just fracture because it's a huge cavity. But then for short term purpose, is it affordable and acceptable? Yes, it is. Pin based amalgam. Well, if you try to put pin in a root canal treated tooth, you might fracture it. So no. RCT post followed by crown, decent option. I mean, you can choose this, but again it follows by crown and post, and that becomes again an expensive treatment. So out of all these options mentioned, for temporary basis, a composite cusp capping becomes the most affordable and acceptable management. So that should be your right answer. Now the following are similarities between amalgam class 2 restorations and inlay, except for, now you see, except, that means all the options will have something which is similar. Only one option will be there which is not similar. So I will start reading my options as this is similar, this is similar. Okay. Occlusal isthmus width. Is it similar? Yes, it is. Depth into dentin. Is it similar? Yes, it is. Both of them require at least 1.5 to 2 mm depth. So yes, it is. Axiopulpal line angle shape, is it similar? Yes, both of them want rounded. No, you don't want sharp line angles. So yes, it is. Divergent walls on the occlusal surface. Well, for inlay you definitely need. For amalgam, slight divergence is recommended as a cavity retention. If you would have read G.V. Black's cavity classification for amalgam, it does mention divergent occlusal wall. It does not mention convergent. But option C, convergent walls on the occlusal surface, is that a similarity? No. Because for amalgam, though you can make a convergent wall because you have to pack an amalgam. So even if my wall is convergent, fine, it's great. In fact, it will help in the retention of my amalgam. But will it allow the placement of inlay? Have you ever made an inlay in the first place? See how an inlay is made. You take wax and you pour it inside the cavity, and then while it is setting you put a toothpick and then you remove it. Now imagine something which is becoming narrow from the top but it's wide on the base, like an inverted cone burr. Can you remove your wax pattern if that was the shape? Because the base is wide, your wax pattern will get stuck in the cavity. You cannot even remove it. Then how will you insert an inlay? How can you insert something which is broad at the base and narrow on the top? You can't. So the divergence of wall is necessary in the cavity preparation. Basically the base is narrow and the top portion of the tooth, the occlusal surface, is wide. Then only inlay can go inside. So it becomes a little destructive preparation for the tooth, but then it's very strong because inlay is like one component on the proximal side. So when you bite, it is very strong. You understand? So convergent walls on the occlusal surface, is that a similarity? No. Because for amalgam, you can make a convergent, but for inlay, you cannot. Getting my point? But you can make divergent for amalgam and inlay both. But you cannot make convergent for inlay. I hope this point is clear. Last. You are inspecting the radiograph of the patient's tooth. The ideal amount of dentin between amalgam restoration and pulp for ideal insulation is 2 mm. Now this is basic dentistry. This question has got nothing to do with your scenario based question. This is a basic dentistry question which they have inserted, and you have to understand and know this point that 2 mm of sound tooth structure is required for insulation. Now let's come to y'all. So there we finished all the questions for today. Next session I will be doing questions from question 7, 8 and 9. 3 questions. 3 questions itself take like 15 minutes, so much to explain. I hope you all understood the concepts today of why pulp sensibility testing has to be done on adjacent teeth, how to read the question with except, all of the correct, etc. All of the questions you see were very basic, but then silly mistakes can be made because if our concepts are not very, very clear. So if you people have any questions, ask me now, then I'll end the session. Anybody with any doubts? Yes, Abir. Chetna Madan, thanks for the session. Oh, you're welcome. Welcome, Abir. Any questions? I give you all a minute. Regarding SBQ question 6, the question already mentioned tooth sensibility test was normal. Then why are we performing pulp sensibility test again? I just explained, Gurveer. It said the tooth sensibility test was normal. It did not mention that adjacent teeth were tested. You remember that? I explained in SBQ 5 why the adjacent tooth sensibility has to be done and not just of the same tooth. That's why. Huma, about radiography case. What happened dear? Question 2, explain it. What was the question 2? This is necrosis. If the pulp is not responding, it is necrosis, no? They are just asking about the pulp status. They are not asking about the periapical status. So I will not say anything about the periapical status. I just have to say about pulp. Pulp is calcified is not the right option because in the radiograph you can clearly see a distinct radiolucent line. So it's not calcified. A calcification would look something like this. I mean, of course, I think this is a radiograph mistake, but do you see this tooth? You cannot see the pulp chamber at all. You cannot see the pulp chamber here also. I would classify this as calcified. This is a very good pulp, but it's not responding and there is periapical thing. So yeah, of course, it's necrotic. Why we give RMGIC in posterior teeth? Because GIC has fluoride and it is hygroscopic. You understand what is hygroscopic? Hygroscopic means water loving, meaning it will not dissolve quickly. Plus, it will not cause sensitivity as it is chemically bonded to the tooth. Composite is cute, it looks pretty, it looks beautiful, but it is mechanically interlocked. It can come out. Micro leakage can happen. So composite is for anterior teeth, plus its strength is not as great as GIC. And that is why GIC becomes the best option for posterior. In fact, if aesthetics was not important, people would be doing RMGIC in the anterior as well. But aesthetics becomes important. You understand, no? A composite is man-made enamel, GIC is man-made dentin. So by picking that option, we are saying that we'll be testing the adjacent teeth as well. Yes, Gunveer, now you got the option. Ma'am, can you please explain inlay question? What do you want me to explain in inlay? For inlay, I would suggest you read, you know what, for inlay, what you should do is, you have never prepared inlay, right? I don't blame you. In BDS, they never teach you to prepare an inlay. Preparation of inlay cavity over tooth. Oh, this is perfect. You see, this is inlay. Now this is the base of the cavity. And you see, this is the occlusal part. The base is narrow than the occlusal, meaning the wall is divergent. Got my point? This is called as divergent wall. Now let's go and see convergent wall preparation for amalgam cavity. Perfect. You see this? The base is larger in size than the occlusal part. This is called as a convergent wall. Now you cannot do so. Again, I'll take you back to this. Inlay has a divergent wall. Amalgam has a convergent wall. You see, this is like your inverted shaped burr. Now when you have a convergent wall in amalgam, it stops amalgam from coming out because you're packing it, right? You don't want the amalgam restoration to come out. But you cannot put inlay in this because inlay is fabricated by the lab. How will you insert something which is larger at the base and narrow at the top? It will not go inside only, no? Hence your preparation has to be like this. Look at this picture. This is converging wall and this is diverging wall. So diverging walls are there for inlay, converging walls you can give for amalgam or inlay, anything, But you definitely cannot give converging walls for the inlay. I hope this is clear now. When twice amalgam is fractured, we check plunger cusp and the opposite arch before we decide through the composite. Yes, but that option is not given now. So what can we do? That's a very good option, but if that is not given in the exam, then I will choose composite restorations. I have no option. But if this option was given, I would choose this option first. Then I would check the plunger cusp in the opposite arch. Any other question? So yeah, it's been 1 hour. Absolutely. I'll end the session. I hope now everything is clear. So what do you understand from this session? Read more about radiotherapy. I shared the article. Read about, you know what? Can I comment here? Can I share something here? I don't know. No, I can't. So read that radiotherapy article. Read inlays. Read amalgam cavity preparation. And solve mocks and practice and practice and practice. Okay. So see you all next Monday probably with question solving of question 7, 8 and 9 of September 2022 paper 1. Bye guys.